and welcome to this month's podcast, where, as always, we're going to bring you up to date with the very latest data in the world of rheumatoid arthritis. And what a wonderful world that is. It's a particularly wonderful world when I have the pleasure of being joined by Peter Nash, Professor in the School of Medicine at Griffith University, Australia. Peter, good to see you.
Great to see you too, Iain.
Yeah, always a pleasure to do business with you, sir. And I always learn, as indeed we all are. You are wonderful viewers and listeners. Now, today we will be reviewing papers by Anna Eberhardt and Reichiro Kanda, in which we're going to discuss JAK inhibitors compared with biologic DMARDs in pain reduction. And we're also going to think about the results from the first registry, as in the first registry, on choosing effective second-line biologic targeted synthetic DMARDs for people with RA unresponsive to first-line biologic targeted synthetic DMARDs. So pretty topical issues. It's treatment switches and pain. And as ever, if you want to access detailed summary slides for the papers that we're talking about today, head across to imedforum.com. I always remind you, imedforum, all one word, imedforum.com. You're going to find the papers there, you're going to find slides there, you're going to find summaries there, and access to a ton of other information, which we hope will be useful to you in your practice. So look, for the first paper, Peter, can I maybe ask you to take us through this one, please?
Yes, of course. Thanks, Iain. This is a paper recently published in Arthritis and Rheumatology, very recent, March. It's a paper that's looking at a very important aspect of rheumatoid management. The patients are only interested in pain, fatigue, and quality of life. They don't care about erosions or swollen joint counts. And this is another retrospective study that looked at the Swedish cohort registry. We like these because they're real world. At least people with every comorbidity and concomitant medication can get into these studies. And it focused on an aspect that's very interesting about the JAK inhibitors, and that is the pain element and the pain improvement with JAKs that we can talk about a little bit down the line. So these are rheumatoids. Real-world type cohort studies have very large numbers. So these had, for example, 1,800 JAK inhibitor patients, but over 6,000 patients on tumor necrosis factor inhibitors, just over 800 those on IL-6 inhibitors, and about 1,000 on abatacept or rituximab. And this is over the years 2017 to 2019, when it may not have been so influenced by oral surveillance and the EMA rules about what you can and can't start, because selection bias is always an issue with these kinds of studies. So previous studies have demonstrated better or equivalent effect on disease activity. And you'll recall baricitinib, RA-Beam, upadacitinib, select compare, when it was compared against the gold standard of adalimumab plus methotrexate, were able to show superiority. And that superiority wasn't driven by swollen joint changes, ESR changes. It was driven by patient global, physician global, and pain score changes. So there's something unique about the JAKs and their effect on pain, and that's what this study was asked to have a look at. There was a previous Swedish study where 1/3 of the patients had high pain levels up to a couple of years after diagnosis, and so this paper particularly tried to compare the JAKs, each class of the biologic DMARDs, on pain in clinical practice treated with standard of care. Now, the demographics and the disease characteristics were similar between the groups. And if you look at the supplemental tables, they allowed all kinds of patients in to this kind of study. For example, 3% had a history of venous thromboembolism. Up to 10% had a background incident of malignancies. So these are really real-world studies. Now, there was no significant difference in change in the VAS pain at 3 months when you compared JAKs with the abatacept or IL-6 inhibitors, but JAK treatment was associated with a greater decrease in pain at 3 months when compared with TNF inhibitor treatment, and there were similar trends that didn't quite reach statistical significance when compared against the non-TNF biologic DMARDs. They used adjusted proportions, remaining on drug. They had an issue with follow-up, which was reasonably short, about 24 weeks, and they had Low pain were numerically higher for patients treated with JAKs compared to those treated with TNF or IL-6, but these differences didn't quite reach statistical significance. They had an issue of missing data, and they did what they could to fix up for missing data. There was smallest sample size really on the JAKs compared to the TNFs as first line, and the reduction in pain at 3 months, again, significantly greater with the IL-6 inhibitors compared to the JAKs. Then they looked at those starting second ever biological targeted synthetic, and again, the JAKs decreased pain significantly more at 3 months when you fully adjusted comparisons with the TNFs and Ritux, and the same was found when comparing with TNF among patients who were starting their JAKs third line or more. So the differences were modest, but there was this consistency across the comparisons that the JAK inhibitors slightly better effect on pain outcomes at 3 and 12 months compared with TNFs, with significantly greater differences if you were onto your second or third line of therapy. And we can discuss why JAKs have this effect on pain, which is a very intriguing effect. So the background, the patients were unresponsive to a couple of biologics, different mechanisms, and this is the real issue. The real issue is people are now trying to define difficult to treat RA and separate it from complex to manage. Difficult to treat defined having failed a couple of biologics, different mechanisms of action with objective evidence of inflammation, either acute phase reactants or on imaging, and that's to be distinguished from complex to manage. And complex to manage is those patients who have pain from damage, fibromyalgia, central sensitization, and they shouldn't be cycling endlessly through biologics when they're complex to manage. They should be down the lyrical line, amitriptyline, physical therapies, etc. So this paper, in conclusion, showed mild, not statistically significant, but a consistent trend across the board that the JAKs were slightly better effect on pain outcomes at both 3 and 12 months, particularly compared to the TNFs. Over to you, Ian.
Yes, thanks, Peter. Crystal clear. You just get the feeling that in many studies now, be they real world, retrospective, be they actually RCTs, if we think about the active comparator arm, which was quite often a TNF inhibitor in the JAK development programs, the JAK inhibitors just seem to kind of creep over the line a little quicker, don't they? They just seem to be that little bit better. And I suppose, it might be that to design the studies that would demonstrate that absolutely definitively would be so huge as to be irrelevant. How do you take that just modest, with an error bar, because we're still not quite sure how the data sit, how do you take that modest potential incremental benefit, lots of provisos in my remark here, how do you take that into clinical practice? What is it you're saying to a patient in front of you at the moment?
Look, I think because of oral surveillance, the JAKs in America, for example, have to be after a TNF, and I could ask you how it's affected practice in the UK. But what's interesting, they're not supposed to cross the blood-brain barrier, even though they're reasonably small molecules. But how do they have this pain effect, Ian? It's fairly consistent, even though you could argue it's not strikingly statistically obvious here. But it's certainly in our clinical experience that patients have a pain improvement that is often quite stark when they have failed a number of other agents or only partially responded. And the theory is supposed to be something to do with inhibition of IL-6 and GM-CSF peripherally, in the peripheral nervous system at least. So I don't think the mechanism is very well understood, but I think you can argue that the JAK-STAT pathway is critical in some of these pain mechanisms, and that's how they have their effect. And as you say, the effect is often quite striking and acute. It happens quite fast.
Yeah.
So I don't understand the pathogenesis, but it is said to be something as peripheral as much as anything else, Ian. And I'm just going to say, I've recently had two colleagues with bad inflammatory disease, struggling after a number of the traditional biologics. They switched to a JAK, and the first thing they said, a dramatic change in pain before any change in swollen joints, etc.
Brilliant synthesis. I mean, I wouldn't add too much other than the following. First of all, I think we still are relatively early in our understanding of how the blood-brain barrier functions, not least for drug entry and extrusion from the central nervous system. So I think that's an open question. Secondly, I think your comments around peripheral nervous system modulation are spot on. For those of you who maybe don't read some of the more immuno-focused journals, one that might be worth having a quick look at is Dana Orange's work last year, who identified actually the neuronal presence and biology within the synovial membrane. In other words, there's a peripheral crosstalk between the immune system and nerve endings, frankly, and that's highly likely to be influenced by JAK inhibitors. And I think we've got just so much more to learn. It's quite fun. Anyway, in clinical practice, I think as ever, we just have to explain the facts as we know them to the patients, and particularly for purposes of a podcast like this, bear the black box warnings very much in mind when we're making those prescriptions, because we don't want to fall foul inadvertently of regulators. One of the other things, Peter, I'm going to use it as a segue. Actually, you made that point about difficult to treat and complex to manage. I have to say, as an old Scottish grammar school boy, I'm really, really struggling to understand the difference there. But I think we know what you mean. And maybe actually you've given me the idea, we must do a podcast on that sometime, just that particular topic, because different societies have gone down a different route in what they want to call things, which is going to cause a lot of confusion in the practicing community. So we're going to have a real dissection. But at least a part of that is making sequential decisions, and that's what the second paper is all about. I can see you're desperate to dive in, Peter, but I'm going to just take a chair's prerogative to say, let's do another podcast on that. I'd love it. I think it'd be great fun. Anyway, let me just dive into the second paper. That actually comes from our Japanese colleagues. This is a group of eminent authors. The senior author here, Yoshi Tanaka, our dear friend in Japan, who just does so many of these great studies. This is the first registry, and it's thinking a little bit about patients with ARIA unresponsive to two or more biologic or targeted synthetic DMARDs. And it's starting to think about the different mechanisms. And Peter's already, I think, given a beautiful synthesis of the challenge we face in difficult to treat or complex to manage. And I think the way you've parsed it out, actually, Peter, is really helpful. So for difficult to treat, for purposes of this discussion, we're thinking about true inflammatory reactive, difficult to control pathway biology, something like that. And we're going to then, that obviously begs the question, what happens when you bring different MOAs into that context? EULAR, for example, recommends you introduce biologic tsDMARDs in phase 2 of the treatment algorithm. We can't choose the right drug for the right patient. Think NordStar, published recently, where 4 MOAs, 4 pretty equivalent outcomes in first decision making. So we're still flying blind in terms of working out what MOA is the right one for any individual patient decision when one is sitting in the room with the patient. For a whole variety of reasons, biologics are often selected more frequently in first line, and that may reflect many things: efficacy, safety, comfort, experience, local health economics, and obviously at the back of one's mind, the black box warnings that Peter's alluded to quite appropriately earlier on. So what happens next? There's no indicator really to guide selection of second-line biologic tsDMARDs. And the paper looks in particular at the efficacy and safety of biologic or tsDMARDs used in second line. And there's a lot of firsts and seconds in here. It was using the first registry, FIRST registry. So that's the name of the registry. Okay, just let's get that potential for confusion out of the way. It's a multi-center registry of RA patients treated with biologic or tsDMARDs. Now, very quickly summarize the data for you. 2,973 patients with rheumatoid arthritis initiated on first-line biologic tsDMARDs during the observation period. Of those, JAK inhibitors were given to one group who had the highest persistence rate, and that seemed to be at least significantly higher than the TNF inhibitor recipient group. CDI remission rate was significantly higher in the JAK inhibitor group compared to each biologic DMARD group. And there's a theme coming through: CDI LDA achievement rate was significantly higher in the JAK inhibitor group compared to TNF inhibitor group. The JAK inhibitor group had substantially lower CDI scores at 4 weeks after treatment initiation than each biologic DMARD group, and also lower CDI scores at 24 weeks. And after adjusting for baseline factors, these included age, sex, disease duration, CDI, HAC-DI, and methotrexate use. The introduction of upadacitinib was significantly more associated with CDI remission at 24 weeks than tofacitinib. Now, important to say, this is a registry. So we're using the word significant comparison in the context of a registry. There's numerous well-known biases, channeling biases, selection biases that will really require us to be very careful in how we make these data into our preferred practice. And I'm sure Professor Tanaka would wish us to be very cautious as well. I know him well, and I'm sure he would wish us so to be. But the idea here is that it's possible that there is a value in the use of a JAK inhibitor if one needs that early control of disease activity. But we do need to be very cautious in observing the national, international guidelines on which patients are and are not appropriately in receipt of a JAK inhibitor, that famous black box warning. And I think we do still need more data. I'm very uncomfortable comparing one JAK inhibitor to another at the moment, and I think we simply accept that was a faithful representation of what happened in this cohort, but I don't think we should immediately infer that one JAK inhibitor is better than another. I think that's really important. Peter, I've sort of almost run out of neuronal power here after all that. Anything you'd like to add to that synthesis? I mean, as ever, it's great data, and we need it.
Yeah, we do. But there are two caveats. One, we've got to change the name difficult to treat, because if the patient gets told you're a difficult to treat patient, he'll be very offended. So we should call it treatment resistant, perhaps. Mm. And I think the implication is, if you can separate out those who are getting pain from non-inflammatory reasons, and you have clearly got a group, most practices 20 or 30%, where they have failed a number of biologics or targeted synthetics. If we could predict them or diagnose them at baseline on clinical characteristics, we might start with combination and then induce remission and cut back to monotherapy over time. And that might mean we have to get the derm or the gastro to write one biologic and us to write the other, as we do in psoriatic arthritis not infrequently. But I think that's really what it's trying to get at. If you can identify the D to T patient at the beginning, whether it's seropositivity, whether it's erosions, whether it's high inflammatory markers, requirement for steroid, etc., then you might treat them differently from day one. Yeah. Rather than what we do now is I'll try that for 6 months, not working, I'll flip to another for 6 months, not working, etc., etc.
Yeah, I completely agree. I mean, no surprise to my friends who may or may not be listening to this that I'm going to seek mechanistic explanation. You look at the work of Neil Basu, it's pretty clear that so-called fibromyalgia in functional brain MRI studies of our patients it tells us that there's real biology going on here, but it's neurochemical biology. It might not be immune biology. And I think you're spot on, Peter, in requiring as clinicians that clinical decision making. There's no point in saying to a patient with clear centralized pain sensitization that I'm going to give you a peripherally acting biologic that's going to solve the problem. That's actually disingenuous, and it loses trust. So I think I really like the way you parse that out. As to the difficult to treat, well, the challenge has been laid down today. We're going to have another podcast to sort that out. When the Scots and the Australians get going at each other, it can be terribly tiresome. So we'll do that another day, Peter, shall we? Look, no, listen, it's great. Let me just bring this conversation to a gentle conclusion by reminding you all, please, that the full publication is uploaded this month. And actually a whole ton of other things. I've mentioned podcasts, abstracts, slides that are really useful for your own perusal, but also for teaching purposes, for others, for training your younger clinicians. They're all at imedforum.com. Don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel. Make sure you don't miss our podcast. How could you possibly want to miss our podcast? I can't imagine what else you'd rather do with your life than listen to our podcast. Well, maybe I can, but it wouldn't be nearly as much fun. And as always, let us know what you think. Leave a review, thanking you particularly for your attention. But this time I want to especially thank Professor Peter Nash. Peter, it's always a joy. You've done some amazing work, particularly I think in synthesizing and leading in the creation of the direct pragmatic advices to all of us in the use of JAK inhibitors in the field. So to actually have the chance to have a podcast chat with you has been a real privilege for me. So thanks ever so much for that, and we'll look forward to our next discussions.
All the very best, Iain. Thank you.
Thanks, Peter. Thanks to all of you. Hope this was useful. See you soon. Bye-bye.